A lot of people will be joining us soon. But I have to start the program, per the CME guidelines. So again, welcome you all. My name is Dr. Vemuri Murthy. I am the program director for this program. I'm also the chairman of the RP webinar CME programs. And I, really appreciate the distinguished faculty from India as well as the United States. And I know, all of you are experts in this particular topic of today, which deals with the Peyronies disease. And the format is as follows. I will be introducing the convener as well as the moderator of the program, followed by the discussions for about an hour and 40 minutes or so. And then the moderator and the rest of the panel, will be actively engaging the participants with any questions. And I'm looking forward to a good quality program with the collaboration of the US as well as the Indian physicians. Thank you. So I'm very pleased to introduce Dr. Amit Chakravarty. He's board certified urologist, chairman of Poplar Bluff Urology, Missouri. He has been practicing adult and pediatric urology for more than 30 years in India, United Kingdom, and since 1990 in the United States. He also holds professional responsibilities as director of Center for Continence and Female Pelvic Health, and is the principal or the primary investigator at Longwood Research. Though his practice encompasses all branches of urology, his main areas of interest are in the field of female urology, including urinary incontinence and pelvic floor prolapse, minimally invasive therapies for benign prostate, male hypogonadism, and erectile dysfunction. He has several publications, presentations, and posters, mostly in the field of male and female urinary incontinence and pelvic floor prolapse, BPH, and hypogonadism at national and international meetings and journals. He is a national and international surgical proctor and speaker for male and female urinary incontinence and pelvic floor prolapse, green light laser therapy for BPH, and intestine therapy. He has been involved in many FDA research studies for device and pharmaceuticals. Dr. Chakravarty was an adjunct faculty for University of Alabama, Huntsville campus, and currently for medical students of Kansas City University and Arkansas College of Osteopathic Medicine. I can also add, he is the current secretary of the American Association of Physicians of Indian origin. I welcome our moderator and convener, Dr. Amit Chakravarty.
Thank you. Thank you for those kind words, Dr. Murthy. And you've been always very, very kind, and appreciate everyone taking this Saturday off. I know a lot of people would love to go out and golf, but let me just tell you a little background about this topic. We decided to do an andrology topic for my colleagues in India. They've got a place called Mayo Hospital in Chandigarh. And I came up with the fact that let's do it on Peyronies. And I came up with a little catchy phrase, let's flatten the curve. And that actually caught on. So last couple of weeks ago, we did this 3-4 hour complete webinar session for India. However, at that time, it was the timings are so difficult that we had to separate this out and make this into a CME on a much more acceptable. There are very few people who wake up at 7 o'clock, 6:30 in the morning to log on. So here we are. We have got amazing faculty, which I'm going to have the moderators from India introduce them one by one. Before we get started, I want to thank ARMS Medical and Cellularity for sponsoring this program. ARMS Medical brings innovative technologies to urology field in partnership with Cellularity that manufactures placental allografts. The reason they are in this, I would like to sponsor this, is that they have dermal and allograft products, which we use as a patch for Peyronies disease. There's a severe curvature, and you'll see some videos of that as we go along. And this is a great, we've got panel who are esteemed masters of their field in USA and moderators who are masters of their field in India. So without further ado, let me introduce the first moderator who is going to introduce the first speaker. The first moderator is Dr. Rajesh Gulia. He is actually the person who actually started the ball rolling with me, and we had been at it for last 4 months, and suddenly, it culminated in a conference called MayoCon, Let's Flatten the Curve. He is in Chandigarh. He's a founding member of the Indian Continence Foundation, the ICF, and he actually has a urology. He's an expert in Chandigarh, and he's also founder member of the chapter of Indian Menopause Society. He authored a book on Atlas of Urethroplasty, an international multi-author book published by J.P. Brothers Medical Public. He heads the Mayo Hospital in Chandigarh. Without further ado, I'll have him introduce the first speaker of the day, Dr. Jesse Mills.
And he is a urologist who specializes in male reproductive medicine and surgery with a busy surgical practice, focusing on vasectomy reversal, sperm retrieval, microsurgical varicocelectomy, Peyronies disease, and penile implants. His clinical specialty revolves around men's health and include male hormone management, sexual and ejaculatory dysfunction, male infertility, and Peyronies disease. He has a special interest in restoring fertility and sexuality in medicine with spinal cord injuries.
Good evening. I'm Dr. Jesse Mills, Director of the Men's Clinic at UCLA and Associate Clinical Professor of Urology at the David Geffen School of Medicine at UCLA. I'm delighted to be here today to share my experience on working with the management Peyronies disease. It's a great faculty we have assembled here, and I'm super thrilled to be part of it. The initial talk will be just to set the framework for how we work up and manage Peyronies disease. And then, of course, most of this will be shared by my esteemed colleagues who will go into much more in-depth management, both intralesional as well as surgical therapy. But let's get started, shall we? I have no relevant disclosures to what I'm going to be discussing today. We'll start a little bit with the history and prevalence of Peyronies disease. Now, this disease goes back for probably over 1,000 years, if not more. In modern times, or at least medieval modern times, in the 1500s, it was described by Gabriel Falloppio as Indoratial penis plastica. And then, of course, it got its name, Peyronies disease, from François Gigot de la Peyronies in 1743. He called it an induration of the corpora cavernosa, so he was a little bit anatomically off. Described it first in a 30-year-old male who had an extramarital affair after having, I believe, 3 kids, stepped out one night and came back with a bent penis, and attributed some of this to a venereal disease. And that thought stuck well into the 1900s, as we'll get to in a second. We know that the prevalence of Peyronies disease varies widely depending on how you ask the question. And upwards of 10% of men in modern series are thought to suffer from some degree of Peyronies disease. Now, of course, in order to be diagnosed with Peyronies disease, for the most part, you need to have an intact erectile function in order to have the erection and see the deviation. So, in fact, the number of men with penile plaques may be even higher than that because we wouldn't know if they weren't getting an erection to have that deviation. This is a textbook I have on my shelf, and it goes back many years, as you can see. And I think it's interesting, a couple of things. The pencil drawings that you see before you are actually what I still draw for my patients today in clinic. And in this development, the authors looked at this more as a progression from an acute phase to a chronic phase. We're not exactly sure that it follows that pathophysiology, but three-dimensional anatomy is pretty good, as you see development of a dorsal plaque there. And they got that this is within the tunica albuginea and not actually in the corpora, as Francois Peyronies thought. But in the 1940s, it was still thought to have some degree of a gonorrheal etiology. and found much more often in sexually active men. One could assume that it was the more sexually active men that were coming in to the doctor complaining of the condition, but in fact, many men were probably suffering in silence and becoming less sexually active as a result of their condition, which we know now is not a venereal disease. The thoughts are that this starts as a chronic inflammation, again, not of the corpora cavernosa, as we thought earlier textbooks, and as we say, the plaques can vary in size, and now we know we see much bigger than lima bean-sized plaques. We see plaques that can take up the entire tunical tissue, and of course, you do see pain, right? And we characterize the acute phase with pain at the point of curvature, or pain generally with erection. The curvature usually goes to the side of the plaque. Now, here's an interesting thought back then, rather than offering much in the way of surgical options dating back into the early 20th century, a little bit of iodine and, of course, mercury cured everything, including syphilis back then. So that was the hydroxychloroquine at the times, I would assume. And it therefore was a very, very effective treatment if anybody wanted to take it. Now, we know, of course, today that none of these things is going to do anything to improve the condition of Peyronies disease, and any resolution was likely due to natural history and lack of progression. So whenever somebody comes into my office today and say, well, Dr. Mills, I don't understand. I have no idea what caused this. They really want cause. They actually want a couple of things. They want to know that they don't have something like cancer of the penis. And I think we all see that you feel a lump somewhere, you're trained in the popular literature to come in. If you feel a lump in the testicle, we know that's bad, you come in. So you feel a lump in the penis, you want to get evaluated for that. So if you can at least set them at ease that what they have is not a cancer, that helps a little bit, but it's certainly not doing anything towards their treatment or to give them the etiology. So we have a nice long consultation where I tell them at the very beginning of the consultation, I'm going to tell you everything I know about this condition. I can tell you how I treat it. I can tell you the pathophysiology. I can even tell you the molecular biology of Peyronies disease, but I can't tell you what caused it. We just don't know. There are things we see that increase in likelihood. History of catheterization seems to come up a lot, especially with and with instrumentation of the urethra in general, and potentially with the history of a TUR, potentially a long TUR with a rigid scope for long periods of time does something to that dorsal aspect of the tunica that leads to this. We don't really know. Prostatectomy is certainly a higher incidence in men after radical prostatectomy, and there's some theories behind that. One of the things that I don't like very often, or I don't like, is men that come in after having erectile dysfunction for 2 years, 3 years, 10 years, and they get a penile injection and say the minute they got that injection, their penis was curved and therefore the vasoactive agent did it. I think a lot of this is the fact the man hadn't had an erection in a long time and he was developing Peyronies in an occult fashion and not necessarily from injecting the corpora cavernosa. So I try the disavowalment of this for the most part. What is the company that Peyronies keeps? There is certainly a genetic component. Some of my Swedish colleagues that I've had the opportunity to work with over the years like to call Peyronies the Vikings disease. It does seem to have a prevalence higher in Northern European latitudes and extending down into Europe proper as well, as you follow the Viking migration in the early 900s. It is linked to an HLA-DQ5 haplotype. Hypogonadism. Dr. Levine, who is one of our esteemed faculty members for this conference, did mention that a few years ago, that about 40% of men with Peyronies do have low testosterone. And then radical prostatectomy also seems to increase the incidence over a baseline, as we talked about. And then certainly the pathophysiology of the Dupuytren's contracture or Lederhost scarring of the plantar fascia, it's exactly the same disordered collagen regulation that leads to the curvature in the penis, the palm, and the foot. So it is a connective tissue disorder, collagen-based. Mostly what we see is type 3 collagen is laid down in place of the more elastic types of collagen and leads to a fixed scar that fixes the tunic in that area and causes the deviation, usually pretty close to the site of fixation. How do we evaluate a man with Peyronies disease? Well, There is some utility in figuring out how long they've had the condition for, whether they are what we call the acute phase or the chronic phase. And we used to assign a certain degree of months to the acute phase, anywhere from 6 to 12. But really the acute phase I characterize by what is their symptom progression. Is the man still experiencing curvature? I've had men that have had Peyronies for a year, but still have gradual worsening of their conditions. I would still consider them acute. I've also had men that have had pain for much longer than that 6 months to 8 months that we typically teach. And if they're still having pain, they're still having inflammation, and they're still having deposition of new abnormal collagen. So it's really the symptoms, not necessarily the chronology. Also, do they have a history of any of the things that we had talked about that may lead you to some degree of etiology? One of the most important things about that first visit for me is that I unload the guilt. I let them know they didn't do anything wrong. A lot of men come in thinking that they masturbated too much as a kid, or that maybe it was an extramarital affair or rough sex or something that led them to this. And I try to disavow them of any traumatic etiology that they were abusing their penis somehow. And then what I've been doing recently, we have a paper in press with the Journal of Urology now looking at the psychiatric ramifications of Peyronies disease because it's profound. We've known since the IMPRESS trials that approved collagenase that there is a degree of psychological bother associated with it, but we can actually metricize. We can measure how significant the psychiatric ramifications are of Peyronies disease. There's a much higher risk of depression, much higher risk of suicidality, much higher risk of men taking antidepressants to deal with the depression that may be, in fact, related to their Peyronies disease. We've all seen the men, if we have had any experience in this condition, that become shut-ins. They lose their social activity because of their concern for sharing their penis and that self-worth that they put into the composition and the function of their penis. So this is a huge thing, and it's something that we're starting to look at more prospectively rather than retrospectively to get a better idea of the psychiatry behind Peyronies disease. As we discussed in the progression of Peyronies, it usually goes into these two phases, which I think are not as we don't use them as much as we need to anymore, acute versus chronic, because it doesn't really matter. One of the thoughts is, if you're looking at doing intralesional therapy, that you wait for it to stabilize. And in fact, we've had some decent papers by Hellstrom. I have one in the literature as well, looking at injecting people in the acute phase and seeing not really any difference in safety or efficacy for doing that. I would caution against treating with something surgically if they're still evolving, because of course you could either under or overcorrect, and certainly you'd want something to stabilize prior to doing a surgical intervention. Very uncommon that this spontaneously resolved. Of all the men I see on a weekly basis with Peyronies, a handful of them will have been told by another urologist that it'll probably go away on its own. There's really nothing you can do about it anyway. So that myth still perceives, and I applaud the organizers of this conference so that we can get a much more evolved word out on the potential for treatment and therapy rather than sitting around and hoping it gets better on its own. In terms of the evaluation, physical exam, of course, after your history, is there, what kind of plaque consistency is there? Is it firm, leathery, calcified? I will say in the age of COVID, I've pivoted to a lot of telehealth visits, and it was awkward, of course, as you can imagine, at first to try to assess somebody with Peyronies disease over the phone. I ended up using a lot to pantomime and holding fingers up and doing this, and to ask a man how his plaque, if he can feel one at all, feels is interesting. Some guys will tell you that it feels like I have a piece of bone in my penis. Well, we know that that's a calcified plaque. A guy the other day said it felt like he had a piece of cooked bacon in his penis. So that gives me an idea that that man, before I even examine him, is going to have a much more leathery but consistent plaque. We also look at the stretch or the elasticity of the penis. Has he lost a lot of length? Because that's a surrogate for length loss. If you're able to pull at the glands and get very, very little stretch away from the pubis, then that man is suffering with significant elasticity loss. And then, of course, the in-office diagnostic injection of an intracavernosal agent to induce an erection. We find that's a little bit more reliable than photographs. People will always still bring in photographs, and other than terrifying my front office staff, I don't think it helps me that much because we know they're pretty unreliable. What do we do about blood work? As we talked about, I do screen most of these men with for testosterone levels, And of course, as a men's health expert, it's amazing how many times men come into me over 55 that have never had a PSA or a prostate exam. And so I certainly use that opportunity not only to treat their Peyronies, but also to make sure they're up to date on their prostate exam as well as their colonoscopy and any other men's health screenings that we should be concerned about. In terms of imaging, the answer is you don't really have to do any of these things, but we tend to do all of them if we're in an academic and a research institution because we keep hoping to gain more and more insight and knowledge on this. So most of my men, especially if they're going to intralesional therapy, will get a penile duplex ultrasound to better characterize the consistency of the plaque as well as look at the vasculature. Sometimes men will get plain film x-rays, and you can see certainly if a plaque is calcified. When we initially did the IMPRESS trial, that was one of the inclusion criteria, was at least a plain film x-ray or a penile ultrasound to make sure the plaque was not calcified. And one of the things that we're doing a little bit more of, and I'll show you a couple of very rudimentary pictures, is employing 3D photography. And I think what that's going to teach us is that our goniometry is probably not as good as a computer in terms of doing the managements with a 3D photograph. We can also perform volumetric assays to assess progress in terms of intralesional or surgical therapy. And so we'll take a look at that as well. That's something that's going to become cheaper and much more readily available in clinics very soon. So on a grayscale ultrasound, you see a calcified plaque right in the middle of the screen with acoustic shadowing. So that's a classic picture of a calcified plaque within the tunica. This is the same patient that has a plain film x-ray, and then you can see that clear as day, the calcification close to the base of the penis there. And here I didn't have the courage to do an actual 3D movie based on bandwidth and everything else. So I took a couple still frames of a plaque excision and graft. And really, this is just indicative to show that's the same penis in different rotations. And you can see the curvature changes dramatically, which again gives you a little bit more information that if you took a goniometer to that left side, it did not look that deformed. This guy's got a biplanar deformity that was actually quite significant with a partially calcified plaque. So this is somebody that would not have done well with Xiaflex and needed a surgery. And then postoperatively, you can see certainly a lot straighter of a penis. There's some already a little bit of subcutaneous edema, so you can see this as a work in progress to see the differences. But again, we're able to do volumetric assays as well and see if we get length and girth expansion at the immediate time of a post-surgical picture or post-Xiaflex. And then, of course, this guy will go through a full another 3D picture in about 6 to 8 weeks once he heals up enough to induce another erection. That's all I have time for now. Look forward to speaking later with our panel about the remaining aspects of all of the talks. And again, it's great to be part of this faculty, and I appreciate the opportunity.
Thank you. Thank you so much. I really appreciate Dr. Mills. Here's what also I have to suggest. We have a chat box, and this program, I told the speakers, unlike the other program, which was geared towards urologists, I told the speakers to basically address general practitioners and non-urology section. So if you have any questions, no question is small. Please put it in the chat box, and at the end of the talk, Dr. Pramod from India, from Bangalore, he'll be asking questions to our experts. So without further ado, let's go on to the next speaker. We've got an amazing set of speakers who are going to speak on different aspects of the disease. So first speaker was on evaluation and management, and second one, and we'll have the next speaker introduced by Dr. Aditya Sharma. Aditya Sharma is an assistant professor in urology at PGI Chandigarh. He's in charge of the men's health clinic at PGI. And he actually did his MBBS from All India Institute and MCH from PGI. He was the recipient of the Young Urologist Fellowship Award from the Urological Association of Asia, ISSM Scholar, and ESSM School of Medicine, that's a European Sexual Society Medicine. His interests are andrology, male infertility, uro-oncology, and minimally invasive surgery. He has published several chapters in books and journals, and has received several awards. He is also a reviewer of several journals and member of various international organizations related to his specialty. So without further ado, I'll ask Aditya to introduce our next speaker, Dr. Landon Trost, who is a very energetic, young, dynamic urologist who used to be in Mayo Clinic, now is in private practice in Utah. So here is Aditya.
Professor Trost is an andrologist and director of the Male Fertility and Peyronies Clinic in Orem, Utah, and he was the former head of male infertility and andrology at the Mayo Clinic in Rochester. He is currently serving on the AUA Guideline panel for Peyronies disease, which will be soon out, last guidelines for 2015. He is the chair of Education Committee for ISSM, chair of Membership Committee for Sexual Medicine Society of North America. He is a member of Board of Directors for the International Society of Sexual Medicine and Associate Editor of Journal of Sexual Medicine over topics of Peyronies disease and male sexual function. He is the inventor of Restorex traction device and has published our largest single-site series, Outcome of Men Undergoing Xiaflex Injections for Peyronies disease. We have three eminent persons for the next session. And it's my pleasure to introduce my teacher par excellence and an astute clinician and surgeon, Professor Uttam Mete. He's a professor in the Department of Urology, PGI Chandigarh. Alongside him, we have Dr. Harpreet Singh. He's the consultant urologist, andrologist, and ex-HOD of the urology department at TMH Jamshedpur, Ranchi. And we have Dr. Rahul Gupta, associate professor, Department of Urology, Super Specialty Hospital, Jammu. Uttam sir, kindly introduce the next talk, sir.
Thank you, Dr. Aditya, Dr. Rajesh, and Dr. Amit Chakraborty for this initiative. Welcome, Dr. Trost. I think I'm being accompanied by Dr. Harpreet. Is there, Dr. Harpreet, and and the young enthusiastic Dr. Rahul. I can see him. So the penis is a very sensitive organ. So nobody would like to undergo any surgery in this organ if there is any alternative. And the alternatives are oral pills or an interlesional therapies. Now let us see whether these things really work or they are just mentioned in the book. Where do we stand today? Let us listen to the expert, Dr. Trost. Dr. Trost, please.
Well, thank you very much, guys. I appreciate the chance to be with you. I'm going to pop my screen up here and go ahead and get started. So good evening to all our colleagues in India. And again, very grateful to be able to speak with you on conservative therapies. And like you mentioned, many patients come in that have no desire whatsoever to go and undergo something invasive. So they're typically looking for something more conservative along the medical management or intralesional line of therapies. And that's what I'll be discussing. So by way of disclosure, as was mentioned, so I invented a traction device during my time at Mayo. They gave me two choices. I could either invest in the company or I could do research, but I couldn't do both. And so I elected to continue to do research rather than invest. I think my wife will always disagree with that choice as the device is going, but it's an important disclosure because that will play into some of the non-surgical therapies. All right, so if you look at the history of Peyronies disease, it is absolutely littered with ineffective therapies. And this has been ongoing for thousands of years that we have information on. So now Jesse went into some of these things, so I won't go into a lot of detail here, but mercurial rubs, is interesting. Some of the early reports said, well, that didn't work, but it did say the holy waters of Barège did work. So the picture on the bottom right there, you can see France and Barège, and supposedly the holy waters there were an effective therapy. Well, mercury and iodide took off a little bit more in the 1900s, and you can imagine what kind of black box warning that would hit the FDA today if you wanted to try to treat with mercury. Surgery really kind of became popular in the 1920s, and I've underlined and bolded the therapies that are contemporary to today. So everything else on the list you can see just fell off over time. So 1920s, we're starting to understand more about radiation, so that's used. 1950s, it especially takes off. You can see the picture on the bottom left there of the radiated water. So this was a real popular therapy to reinvigorate your life with radiation. Steroids start to pick up in the 1950s. 1960s, we start to see DMSO, and that is now experiencing a resurgence due to blogs and chat rooms and things like that. 1970s, the implant, of course, comes around, immunotherapy. We almost see a tracing of the history of medicine. Basically, anything that is new in medicine that's invented, people throw at Peyronies disease in hopes that it'll work. And And as you can see, they're not underlined or bolded. They don't work. And that's parathyroid hormone, propranolol, cesium. 1980s, collagenase is first starting to be discovered. Beta aminopropanol, laser therapy, superoxide dismutase, prostacyclin, tanoxicam, all of these start to get picked up in the 1980s. Shockwave. Many people don't realize that this is the time when shockwave therapy started to be used. 1990s, we really start to get the intralesional therapies. So intralesional verapamil, interferon. 2000s, we get some novel graft materials like collagen fleece. Traction gets picked up in the 2000s. And then 2010, we have some new agents that are around. Blueberry is making a resurgence as well, sliding techniques and so on. So you can see there's really a very broad history of non-surgical therapies which have been attempted. But before jumping into, what do the data show on these, I think first things first, whenever, and Jesse got into this a little bit, but not every guy that comes in is really seeking to improve their curvature. Some are specifically looking at penile length. Others care most about the hourglass deformity or buckling. Others are really looking for more ejaculatory type things or erectile function. Some pain is the main issue. So it's very important to really understand what you're treating, because the types of treatments you're going to use are not going to be one size fits all. If you're treating length, for example, traction is probably going to be your better therapy. There's some who would argue for surgery here, but not many. Pain, your therapy may be to do nothing. Just give it time. It will resolve spontaneously in essentially all men. Or you may look at something like interferon here, and we'll show that data here in a minute. Deformity or hourglass, this one's tricky because there is no good way to objectively measure this. And so any data that's out there can't really prove conclusively if it improves or doesn't improve deformities such as indentation or hourglass. And finally, curvature, this is what we're going to focus the most on. Most data out there is focused on curvature, so we're going to look at that one more specifically. All right, so what do people actually pick? We looked at the data at Mayo from 1990 to 2012, and during this time there was a provider who specifically recommended surgery as the main recommendation for therapy. And we basically sent a survey to all of these guys, I don't remember how many thousand it was, but several thousand Peyronies patients, and said, what did you actually end up doing during your entire life with Peyronies disease? And you can see from the images here that it's conservative therapy. So the far majority of options that they picked were, pills or vacuum devices, and even, injections, traction, topical, even though they weren't recommended at the time, were preferred over surgery as a conservative group as a whole. Well, so if we break down medical therapies, we're going to break it into topical, oral, and injectables. Topical therapies, the concept here is that you get enough of the drug that will elute through the skin into the plaque and cause an effect. This can be done with or without ionophoresis. There are many therapies which have been described in this way. Oral, on the other hand, is this concept of systemic penetration of the plaque, that you take a pill and enough of it gets into the plaque itself that you can get some effect. And there are dozens of therapies which have been looked in that regard. Intralesional, you directly put the injection specifically into the plaque. You get a much higher concentration of whatever drug you're trying to deliver. The common ones here are going to be verapamil, hyaluronic acid, interferon, and collagenase, although there are others which have been described. So moving into topical therapies, and again, it's a brief talk. I mean, you could easily give an hour-long talk on any one of a single agent of any of these categories. So this is very high level, that we're going to be reviewing. So the issue with these in general, and this is a big, broad, sweeping brush, so take this with a grain of salt. But of the topical therapies described, they're impeccable because they're nearly all pilot studies. They're nearly all randomized controlled trials, and they all have very poor methodology. And that's not meant to be a dig or a complaint in the sense that with poor methodology, you can't really detect a lot of things with Peyronies disease. Peyronies, as we know, evolves so much on its own with or without therapy that if your methodology is not good, where your investigators are blinded to their initial results, where you're doing very large numbers of patients, where you have a mandatory control, where you have a sham type therapy, the methodology is just not able to answer questions about Peyronies. And interestingly, a lot of these topical therapies have these remarkable, results. So you look at the verapamil, trifluoropyrazine, and magnesium sulfate study. This is an older one, 2007, but it highlights the point. They reported 94% of men had improved curvature, and and shockingly, 61% of the curve improved. So again, you take someone with 100 degree curvature and they're down to in their 30s and 40s with topical therapy here. Plaque volume decreased in 85% and pain resolved in everybody. More recently, so topical therapies have continued. It's not just these. Again, there's dozens here. But H100, so you've got emu oil, nicardipine, superadviscide dismutase. They reported a 23% length increase. Again, so this is a topical therapy on someone with Peyronies, and they're getting length increases. 41% curve reduction, 86% pain reduction. And again, this one is criticized because they had to go back and disclose conflicts of interest with the therapy. But there are many, many, many more. And again, they're all remarkable in the results that they have for it. But the main problem with topical therapies in general is that the therapy never actually gets to the plaque. So a landmark study that was done by Mulhall's group in this regard, at the time, topical verapamil was a popular agent. And they basically applied topical verapamil the night before, the morning of, so right before a penile prosthesis surgery. And then they did a penile prosthesis, cut out a portion of the plaque, about a gram of tissue, and then they sent it for mass spec to see what is actually in the plaque. And surprisingly, they found no verapamil at all. They found verapamil in the urine. In other words, it went into the skin, into the lymphatics, and the bloodstream, and then it went throughout the body. But none of it actually made it into the plaque, even though it was being applied, topically. So the AUA guidelines recognizes this. Every topical therapy has the same statement where it says replication of a high quality randomized design with a larger sample size is needed before it can be recommended as a PD treatment. They do have a very specific negative statement saying electromotive therapy with verapamil is not recommended in that regard. All right, so moving on to oral therapies. So there are many with reported benefits. You've got vitamin E, tamoxifen, colchicine, all of these others. And they all have great in vitro mechanisms. They're either antifibrotic or TGA beta blockers or receptor downregulators. They may inhibit fibroblast migration or development. So they all have great mechanisms as to why they should work. But in reality, they don't make sense in vivo. For one, this would require administration immediately. As we know, the majority of fibroblast type activity is going to occur early in the phase. So the first maybe 2 weeks of disease onset, this would need to be applied. Secondly, in order to get a high enough dose within the lesion, you have to have essentially toxic doses of any of these therapies to get anything in. But the real issue with oral therapies is the data is either completely lacking, it's contradictory in nature, or it's been retracted due to falsification. So pentoxifylline is a real famous one here. This had, supposedly some of the most robust evidence, but the main person who had done the original randomized controlled trials was found to, or was suspected of falsifying data, could never prove the data, and all of his studies have been withdrawn from the literature. And that was the best we had, as far as oral therapies. So AUA guidelines, again, recognize this. They state specifically clinicians should not offer, the following therapies. And it's telling also that there are no statements recommending any oral therapy whatsoever for it. All right, injection therapies. So this is where, the main data is going to be located. So looking at verapamil first, there are 2 randomized controlled trials that are out there, and then one that's randomized without a placebo. And you can see the first one, 80 patients, no significant differences in curvature, pain, plaque size, sexual function. The second one didn't have a placebo group, but it essentially showed that the improvements in curvature occurred when you did a higher volume versus a lower volume. So it wasn't the drug itself necessarily, but it was the volume of fluid being instilled. And then the third one here compared hyaluronic acid to verapamil and showed no change in curve compared to baseline, which was how they acted their control there, and no difference essentially between agents. So interferon alpha 2b, this has a little bit better data in general. So this is a single-blinded, not a randomized controlled trial, but it did have a placebo arm, and it was a parallel study. They had a total of 12 weeks or 6 injections. So I apologize, there's a typo in the middle there. Interestingly, it showed pain resolved in the majority of men with interferon compared to controls, and curvature was improved. So to me, this says there is potentially a role for resolving penile pain more rapidly. But interestingly, there's no contemporary studies of interferon alpha, and we'll show perhaps why here in just a second. And then, of course, many of us have seen the data on collagenase. This is the IMPRESS trials, the data from that, and it shows that there is a statistically significant improvement compared to placebo. So this data is just IMPRESS right now as far as the figure on the right. But on the left, there was a meta-analysis performed recently of all of the different randomized or parallel arm studies And it showed that verapamil and hyaluronic acid did the worst overall. Interferon and collagenase did the best. But again, they didn't correctly classify all the data. They said they're all randomized controlled trials, and that wasn't accurate. So that data analysis wasn't perfect, but it did show the trends that we're seeing from individual studies as well. On the right, you can see a paper we have in press right now that shows comparing interferon, which is going to be your red bars, to Xiaflex or collagenase, the blue bars. You can see that basically collagenase does better than interferon at basically every step. So every one of these lines is an individual patient who had baseline and post treatment data. And you can see that collagenase just does better in general. All right, so the guidelines say you can offer interlesional therapy with interferon or verapamil or collagenase, and they gave very specific criteria for collagenase, but they didn't have any commentary on which therapy may be preferred at the time. Well, in reality, combination therapy is probably most important as far as what's contemporary management looking like as far as interlesional therapies. There's a randomized controlled trial out of Italy that showed collagenase and sildenafil did better than collagenase alone. They showed 26-degree improvement versus 17. And the mechanism there may be you just get greater erection strength, and so hence you get greater internal traction. And then our data here compared Restorex traction with collagenase versus without. And you can see the green bars show the application of greater traction with collagenase is probably the key to getting better outcomes overall. Well, in addition to that, collagenase has some real advantages in that it achieves some of these key clinical outcomes. So if you said what percentage of men post-collagenase could now penetrate, whereas they couldn't before, you can see in data that we showed at Mayo, it was close to 60%, which is not bad. I mean, it's not 100%, but now you've salvaged about 2/3 of men with a non-surgical therapy. Of men who basically said, did this prevent them from needing surgery? It's about 55%. And then sensitivity, basically, you didn't get worsening of a sensitivity with things. So you're not seeing a lot of downsides or side effects, but you're seeing a percentage of men who are captured or salvaged from needing surgery. So what are physicians actually recommending if you look at trends? So since collagenase was released, it's gotten to a point that physicians are now recommending anywhere from 2 to 3 to 1 collagenase as a first-line therapy over surgery. So in summary, as far as oral and topical therapies, there's just not enough data. If you're going to use it, you want to do it early, really within that first 2 to 6 week time frame. There are some therapies you definitely should not use, and topical therapies, the burden of proof is on them to prove that anything actually gets into the plaque before those can ever be recommended. Injections, collagenase is likely the best overall. Your best outcomes are going to be when you combine it with specific traction and sildenafil. Prior meta-analyses show that collagenase probably did a little bit better than interferon just because of the way the meta-analyses are performed. Interferon's probably better now as a second line or in people who don't have coverage for collagenase, or if collagenase is ineffective, is possibly a second line. But likely there's no contemporary role for verapamil or hyaluronic acid based on the current data. And with that, I thank you very much for your time.
Thank you very much, Landon. That was an excellent talk. I need to unmute my video. Yeah, that was an excellent talk, and I think every speaker is covering part of it. This time, Landon covered non-surgical treatment options, and so that's basically what it did. And again, next person who is I'll actually request Dr. Gulia again to introduce the next person's thing right now. Okay, hang on 1 second. 1 second, let me just stop share here. 1 second. All right. Vijaya has stepped out for a second, so I'm going to actually try and introduce आदित्य आदित्य तुम्हारा स्क्रीन आ रहा है ना? You've seen, I'm actually sharing the screen. Okay, so are I not ठीक से आ रहा है? Okay, good, thank you. Okay. Okay. Okay, basically what happened is that no, now it will come. No, I muted for some reason it got muted. Okay. Yes. I just talked to India. They said that they can hear it. So what do you want to do? Let me talk to Dr. Murthy again. Just a minute. Hey, Dr. Murthy, can you hear right now? Yeah. See, what happened was, Vijay was the one who was asleep. He wanted to so I had to do the screen share. The problem is that I didn't realize that if I mute myself, my screen share also will be required. So I am not sorry, right? Okay, now there will be no problem. I just realized that if I muted myself, my screen share also.
No problem. We'll resume. Thank you.
Let's continue this. After that, hey, okay, yeah, I'm going to stop it. I'm going to stop it, and I'm going to. You start from 9:21. Okay, 9:21. Okay. Yeah. Guys, we have a little issue, and I'm going to have Vijaya take over. That's what happens when I take over stuff which I don't know much about. So I'll have Vijaya take over, and she will continue from this particular part 9:21 of Dr. Levine's talk. Vijaya, can you take over, please? Dr. Levine's talk from 9:21. She's going to share the screen. There you go.
Reduction in the population.
Perfect. Thank you so much.
Quite meaningful. And there was increase of length in that population up to 2 centimeters. There were fewer dropouts. There were fewer people that went on to surgery. But also important, I think, in this study is that we found that in that responder population, the mean daily traction was 3.6 hours. So we defined at that point that a 3-hour per day minimum was needed when using the fasciitis type or andropenis type of design to initiate that mechanotransduction process to get the kind of results we saw here. Sorry. Another study that Dr. Trost already referred to, and that is the combination of Xiaflex with the Restorex. They divided these patients into 3 groups. Some just got the Xiaflex or collagenase only, up to 8 injections. The second group was using the Xiaflex with traction, but not using the Restorex device. And then the third group was the Xiaflex with the Restorex. And if you look at under the results, we can see that that with respect to curvature reduction, the group 3 that received Xiaflex with the Restorex did the best. They had a, pardon me, 34-degree reduction of curvature with up to 49% reduction there. There was also improvement of length in that population. So group 3 was more likely to experience at least a 20-degree or a 50% reduction of curvature, to also experience a 1 centimeter more length gain. And this was even when controlling for what I'd said previously, that you want to have at least 3 hours with those types of devices used in group 2. So they concluded that the combination of the Xiaflex with the Restorex seemed to result in better curve and length improvement. The concern I have about this study is that 174 patients were excluded, and if you look at group 3, there was only 16 patients in this study. I'm sure Dr. Trost and his group are looking at this in terms of larger numbers and probably confirmed that this is true, but it was certainly a limited number at the time. So let's switch to surgery. The indications for surgical reconstruction are shown here. Stable disease, at least 6 months, I think is reasonable. Painless deformity. We should also recognize that some people will have torque pain, even though they're in the stable phase. They may have pain when they have a strong erection or engage in intercourse. This is not, I think, inflammatory pain. So we want the inflammatory pain to be over. That they would be compromised or unable to engage in coital activity secondary to their deformity or inadequate rigidity. They've failed conservative therapy. Some patients with extensive plaque calcification aren't going to be good candidates for any non-surgical treatment. But the group that I see that ultimately want to have surgery are those who desire the most rapid and reliable result. We published, I think, the first surgical algorithm back in 1997 for patients who had good erections with or without pharmacotherapy. That meant PD-5 inhibitors. And if the curvature was less than 60 degrees and there was no hourglass or hinge effect, we recommended tunica plication techniques. And if they were worse in terms of deformity with regard to curvature, or they had a destabilizing hourglass or hinge, then if they had good quality erections, then incision and grafting procedure would be recommended. How does this compare to the AUA guidelines with respect to plication? I don't think it really provides us good guidance. It said, basically, if you had adequate rigidity with or without oral therapy, injection, or vacuum device, I don't altogether agree with this. And there's no mention, pardon me, no mention of a degree of curvature to use with plication. And the same guidelines are used for, in number 19, for grafting. On the other hand, the European guidelines are more clear, I think provide more guidance with respect to plication. Again, they have to have stable disease, but they should have adequate length. That's usually being determined by the patient. The curvature would be less than 60 degrees and absence of hourglass or hinge. So similar to what we had originally published in 1997. But with grafting, the patient could have inadequate penile length, meaning they felt as though they've lost too much length to sustain application, or curvature greater than 60 degrees, or presence of hourglass or hinge effect. So what's the goal? Pardon me again. What's the goal of surgical algorithm? Well, to provide a functionally straight erection. Most men will be able to do what they need to do. I'm not going to be bothering their partners or themselves with a curvature of less than 20 degrees. We know that's within the realm of normal. To preserve or improve rigidity and minimize shortening. But we also have to recognize that there is some variation with respect to patient preference. And I think this pertains to injection therapy and to surgery, because there are patients who simply won't undergo a plication operation because they're fearful that they're going to lose more length. And there are some patients who should have a penile prosthesis because they have diminished rigidity, but they outright refused to take that recommendation. And oftentimes are going to have maybe a grafting operation, which would be ill-advised, but willing to take that chance. With respect to the types of surgical plication techniques, you can see here, we have the Nesbitt, the Yachia, Tom Liu's 16 dot, and the approach that I prefer, that I'm gonna show you some slides on, so-called Duckett-Baskin tunica plication. All of the plication procedures do shorten the long side of the penis. Here's a Nesbitt approach where you excise these ellipses on the convex side to basically shorten the long side to equal the shortened scarred side. Daniel Yachia's approach using the Hanke-Mikowitz principle. Here he's attempting to straighten a dorsal curvature. So this is one of the two incisions that would be on each side of the urethra. So you make a longitudinal incision and then close it transversely to shorten that ventral aspect. Tom Liu's 16 dot procedure is dependent upon a large non-absorbable suture, Tycron or Tebdek, in a sort of extended Lambert fashion. So on the left of that cartoon panel, you can see correcting a dorsal curvature. You're going to place your sutures on either side of the urethra to shore up that tissue on the ventral side to correct the dorsal curvature. So you're really relying upon those stitches not tearing out or the knots not loosening. And unfortunately, I've seen quite a few of these patients who have had recurrence after having a 16 dot procedure. So my preferred approach is the tunica albuginea plication. Here we start by measuring stretched penile length in the operating room. We always do this with every visit I see of Peyronies disease in the office. I get their measurements because they're frequently saying, well, you know, we did this treatment, one thing or another, and now I'm shorter. And you can at least best objectively determine whether there's change by doing this measurement of stretched length by pushing down on the pubic bone with a rigid ruler and pulling up on the penis and measuring. I measured to the corona, and you can see this gentleman is 9 centimeters. We now create an erection after degloving the penis. You can see he has a little bit of a lateral curve and some narrowing. And if we take another dimension, you can see he's also got some dorsal. So dorsal left lateral curve. We measure this with a goniometer, try to document that in the operating room and in the office when you do duplex ultrasound. And then elevate Buck's fascia. And in this patient, because it was a dorsal left lateral curve, we elevated Buck's fascia off of the ventral right lateral aspect. And here's the Buck's fascia elevated. We make a pair of transverse incisions. And these incisions, as you can see, do not expose the cavernosal tissue. So there's less, I think, risk in that regard of causing some corporal tissue fibrosis. But we make the incisions through the longitudinal fibers. And then we shave out that tissue between the two to reduce the bulk of plication. We mark it for visualization during the procedure. And then I place a single central 2-0 Tebdek suture in an inverting vertical mattress fashion that buries the knot deep to the surface. And then reinforce each one of those plications with 3-0 PDS placed in a Lambert fashion. So this particular, we had 3 plications on that right side to correct the curvature. And then close the Buck's fascia again. This data comes from the latest Campbell's textbook and basically shows data for plication procedures. Basically, you can see that it's one of the more modern techniques. The modern data shows high 90% range of straightening, minimal change in erectile function, and where it's been actually studied, reasonably high satisfaction rates from the patients who underwent this procedure. We recently published a series of men who were over 65, and using the original algorithm that we had, we found 86 men who were over 65 who we performed surgery on. 25, we'll focus on just under the TAP group there on the left column. 25 of them had a plication with a mean curvature of 61 degrees. And bottom line was that 92% were engaged in penetrative sex, and there was an 88% satisfaction. So again, even in the older man, and I think Jesse referred to that, Jesse Mills referred to that earlier, is that is, you know, you don't necessarily, because they're older, necessarily have to go to a prosthesis unless they're not having good quality erections. And in this case, we had very good results with the plication technique. We also elected to try to modify the original design of plication, which used non-absorbable sutures, but there were a lot of complaints in the literature that had been published about recurrent curvature or pain or bothersome nodules because they could feel the non-absorbable suture up to 88% in some papers. And we had 142 patients who underwent our modified plication, where we used that single central 2.0 TEVDEC and then reinforced with the 3.0 PDS. We had 81 patients who completed the survey with a mean follow-up of about 4.5 years. And we had residual bothersome curvature of only 6%. Importantly, only 5% had bothersome nodules as compared to the previously published literature up to 88%. And less than 3% ended up having a repeat procedure of any sort for that entire group. So I think we can use less permanent suture and realize that we're not going to have recurrence because the sutures broke or tore out or dissolved too quickly. That just simply doesn't happen. So the plication procedures, I think, have certain advantages. It's simple, they're minimally invasive, and I think it preserves potency in most patients, certainly if they're good preoperative potency. I think there's less likelihood of having ED issues as compared to the grafting procedure. The cons of plication is it can result in perceived penile shortening. That may be modified or reduced in its severity if you use traction after surgery, but the procedure itself might, by definition, causes shortening. It's best for smaller unidimensional curves, and again, I say less than 60 degrees. And yet it can worsen narrowing or hinge effect. So if a patient has a partial indentation on one side, you have to correct the curvature on the opposite side. You may exacerbate that narrowing and create a real hourglass. You have to be careful about that. In 2010, I was chaired the International Consultation of Sexual Medicine with Dr. Ralph from London. And then in 2015, there was the next international consultation with Dr. Ralph and Dr. Chung. And the agreement then was that with respect to plication procedures, there is no evidence that one surgical approach provides better outcomes over another. So whatever you do, whether it's a Nesbit or a 16 dot or a TAP procedure and it's working for you, you certainly continue with it. And curvature correction can be expected with this approach with a low risk of new erectile dysfunction. Well, thank you for your attention.
Thank you so much. That was an awesome, let me take the video. That was great, Dr. Levine, and really appreciate your insight on part of the, there are two types of corrections for Peyronies disease. One is the plication and traction devices, which he alluded to. And the next option is where there's a severe curvature and we actually do excision and grafting, or incision and grafting to make the penis straight and also regain some of the penile length. So without further ado, I'll actually have, I think Aditya is going to introduce the next speaker, who is Dean Knoll, a long-term, very long friend of mine. He's in Nashville, and we go back 25, 30 years. We used to proctor together. For the last 25 years, we have been proctoring, and he's a great, great friend of mine, and he helped me put this session together. So Aditya, go ahead.
in penile prosthesis implantation and in treatment of men's sexual health. He is the director of the Men's Health Clinic and Reconstructive Urology at Urology Associates in Nashville, Tennessee, where he practices. Dr. Knoll has performed over 7,000 urological prosthetic surgeries, including penile prosthesis, Peyronies disease prosthesis, urethral slings, and sphincters for urinary incontinence.
Well, first of all, I'd like to thank all of you for giving me this opportunity to participate in this presentation on flattening the curve. I've been dealing with Peyronies disease for 33 years, and it's funny how the surgical evolution of straightening a penis has changed. Remember in the late 80s and early 90s, we used to take out all of the scar, the Horton Devine procedure, and 85% of those patients became impotent, required an implant. So that obviously wasn't the best operation, and we kind of abandoned it. Then we went through into the plication process, and that was very well presented by Dr. Levine. And obviously, it's not ideal for every single patient, but certainly there's a role for plicating some patients. I see a lot of patients that are referred to me that have very, very severe Peyronies disease. They have large plaques. They have very significant hourglassing many times. They'll have indentations from their Peyronies process. And these patients have very severe curvatures, 60 degrees or greater, where I know if I was to plicate them, I could straighten them, but certainly I know that they certainly were going to lose some additional length. Patients who become candidates for grafting are those patients that I just mentioned. Very severe curves, hourglassing, indentations, and those are the patients that may benefit from a grafting technique. Obviously, the surgical treatment, Larry's addressed this beautifully. We want them in the chronic phase. Of course, there's no single operation that's ideal, or else we'd all be doing the same one. Again, what are some of the benefits from excision of the plaque? Obviously, you don't usually decrease length, which you could with a plication procedure. And certainly we've learned a lot about the grafting materials that come about, and I'll explain how I got into grafting in 1998 using SIS or Surgisys. Patients who are impotent, of course, those are the patients that require an implant. Later on, I'll show you a patient who was impotent, had bad Peyronies, who had an implant, didn't lend itself to modeling and required a grafting over the implant. So we'll share that with you in the next presentation. Again, there's no ideal material. I think we've now realized that the autologous grafts are not that great. The xenografts have been proving to be more durable and decreasing the risk of fibrosis or recurrent curvature. When I first started to do grafting in August of 1998 is when I put SIS into a penis. That's the submucosal graft from the jejunum of a pig that's obviously rendered acellular, and it's type 1, type 3 collagen. And when I heard it was type 1, type 3 collagen from the plastic surgeons talking about it, I said, how does it work? They said, well, it works because it needs blood supply. And after it gets this blood supply, it will integrate into the tissue it comes into contact with. So when I heard that, I called Cook Urologic and I said, I want to put this in a penis. And they said, well, it's never been done. I said, well, we need to do it. So why I'm bringing that point up goes to the point with regards to graft contracture. So my first 5 patients that I did them, rapidly in a couple of week time period, because I didn't really know what I was doing with regards to the grafting. So it was a single ply. I folded it over multiple times to make a 4-ply. That's what I use now. But I cut them to fit. And what I found was that there was contraction of the graft and they had recurrent curvature, not to the degree that they had before, but certainly they had it. So I learned a lot with regards to making the graft now 20% greater than the defect for potent patients. And if I'm grafting over an implant, I make it 10% greater than the defect because I want it to contract down onto the prosthesis itself. The most significant change or problem that I tell my patients if they're going to get a grafting procedure is they run a 20-25% chance of having ED afterwards, even though they didn't have it going in. And that's a significant number of patients, but they're willing to take the procedure knowing that that's the only thing that they probably are a good candidate for at this time. And then I said, I can always make you potent if that becomes a problem. but it does become a problem. The grafting materials, as I say, I think number 5 and number 6, we're using the xenografts. And these are the ones that tend to allow us the best opportunity to get a good intake of this biomaterial that gets integrated into the collagen of the tunica albuginea, which is again type 1 and type 3 collagen, and that's the same thing that SIS and pericardial grafts are, type 1 and type 3. We no longer use synthetic grafts. They never gave a great cosmetic result. And any of the other autologous grafts just really didn't work very well. There's a few principles, of course. It's paramount if it's a dorsal lateral curvature that you have to isolate the neurovascular bundle. If it's ventral, we'll have to isolate the urethra. Obviously, I marked the center portion of the plaque, the most concave portion of the curvature, make a relaxing incision into the tunica with care given not to damage the underlying cavernosal smooth muscle. I will extend the lateral margin of my incision into the tunica near the corpus spongiosum to make an upper H-type configuration because it allows the graft not to make an indentation, which is what I didn't do in the very beginning. So this upper H configuration allows the graft to lay in more smoothly, and it allows it to make symmetry to the shaft of the penis, particularly if these patients have had hourglassing or an indentation from their Peyronies. The graft again is 20% larger than the defect, and I run it in, with a PDS suture, and it's absorbable, and it takes some time. Just briefly, there's been many published papers with regards to free graft. This is the tunica albuginea free graft. This is using temporalis fascia that's reported. They have around a 7% ED chance of, or the chance of developing ED. There's venous patch data that's been placed and published. There's several authors here. The potency is over 90%. I'm not sure I can gain that particular percentage. My patients around 75% maintain their God-given potency that they had before and don't require aid afterwards. Here's a procedure with human pericardium. There's a 98% success rate. This is Larry's paper that he published in the journal Urology. And like myself, we both chatted about this before in the past. Those patients require assistance post-operatively around 25 to 30%. And I concur with that. There's other data that's been published as well. And here's the one I published in 2007 on the first 162 patients I did. 21% of those patients required some form of therapy. And of those 21%, 10% of those patients needed an IPP. And I really couldn't figure out which ones would be doing the Doppler before and after. It just really depended on how that patient absorbed the graft and how the veno-occlusive mechanism of closing would become after that procedure. Here's the SIS graft. We just soak it in saline. It comes from the jejunum of a pig. It's rendered acellular. There's resident cytokines and glycoproteins that allow the absorption of this graft once it gets irrigated. Even a patient's penis that's not very well functional is still pretty well irrigated, and subsequently that's why I thought this would be a great graft to use in our Peyronies patients. The thickness, it's very tough. It's good stuff. It's burst strength, you can see a burst force is 28.5 pounds. So once it's sewn in and you don't have any leakage, so I run my sutures very close together, those patients who get erection nocturnally in the immediate post-op period, they're not going to blow out their graft. So it does have a very good burst force to it. Again, here's just the procedure. You do a degloving procedure. You incise Buck's fascia. You deglove the penis, take the skin and incise through Buck's fascia down towards the base of the penis. I create an erection and I document the most concave portion of the curvature. This is done with the neurovascular bundle then being isolated. It's marked, and subsequently, again, I just make a single incision through the most concave portion of the curvature, and then I create the upper H configuration, which you can see in this particular slide. So the neurovascular bundle is isolated. You can see that the incision is made in a single solitary manner, but it's widened. And then at the level of the corpus spongiosum bilaterally and the contralateral side as well, I will then make this upper H type configuration that you can see. In the early days, I made it just as a V. The cut would come down to the corpus spongiosum and it would heal that way. There would be an indent right there. And I thought I need to change that. So subsequently, that's when I went to widen the tunical incision. And this is usually normal tunica because the Peyronies usually is more located in the dorsal midline of the penis when there's pure dorsal curvature. But widening this allowed me to get a better cosmetic result, and the absorption of the graft eliminated this hourglassing type process. So the graft is made 20% greater than the defect. I take a 4-0 PDS suture and I run it in, and you can see how the graft is now situated in underneath the neurovascular bundle. And these are the patients then, this is the postoperative result that we see from that particular patient. These patients can also have, this is showing a ventral grafting procedure. When someone says to me, when is it that you would never graft a patient? Well, I can tell you, if this patient here that I'm demonstrating this ventral curvature, and actually he probably would have been fine to do a plication procedure on. But if there's a patient that's a diabetic and has a ventral curvature that looks like this, I will never graft that patient because you run a high risk of losing your blood supply to the glands itself. So if it's a ventral curvature in a diabetic patient, they get plicated. I will never do a grafting procedure because I've seen patients shift in that have had that where the glands has become necrotic. Here you just isolate the corpus spongiosum off of the most concave portion of the curvature, again incised down, care given not to damage the underlying cavernoso smooth muscle. You measure the defect, you sew in the graft, and this is the postoperative type of result that you will see. So when I do these patients, I tell them they're outpatient procedures. I leave a dressing on, just as a seriform dressing around the subcoronal incision and a loose 2-inch cling dressing, and I leave that dressing on for 3 days. Other than that, the most important thing that the patient has to do is to wear his penis 180 degrees opposite his curvature. So if it goes up to his left shoulder, he needs to wear it to his right toe. And I tell him it's very important to do that for the first 8 weeks postoperatively as best as they can. What happens with the penis? They get straight. They really do can get 91% of these patients I saw in the early days. They had penile straightness that allowed them to gain function. When dealing with Peyronies patients in the surgical aspect, I always tell them, you'll never have your penis look like it was before you had Peyronies. And I always tell them, if I can make your penis 18 years old again, you get the operation second because you're going to be behind me. I'm first. So obviously we got to expel, unrealistic expectations with these patients. There can be some recurrent curvature. It usually doesn't require another reoperation. Of course, I've learned to get rid of this indentation by doing the upper H type configuration to the tunica albuginea to prevent that. But most importantly, because it is, even though it's a foreign body, but it's a collagen graft, infection has not been a problem with this particular process. Length loss, that's very unusual because I tell them you're going to gain whatever length that defect opening will create. And again, there's not been permanent hypoesthesia because of the great care given to isolate the neurovascular bundle. And again, this is the most important part. I tell these patients, you still run a 20-25% chance that you're going to need aid afterwards to get the erections, whether it's oral therapy, whether it's injection therapy, and of course, the possibility of having a penile implant being required. So that would be the first presentation that I would like to share with you at this time. The next one is the one that will be the surgical video. And I may need somebody to help me get that one up.
Yeah, I'm going to be playing it, Dean, and we are all set, ready to go. I'm going to actually share my screen. You have to, can you go ahead and unshare? There you go. Can you guys see it? I'm going to rewind it a little bit. Yeah, there you go. Everybody can see it?
Yes, yes, you can.
All right. We all know how we prep our patients now. And we're using ChloraPrep. This is an infrapubic approach. This patient actually had bilateral inguinal hernia repairs. So I'm showing a little technique by opening the anterior rectus fascia. There's a septum in the midline, and I've opened the transversalis fascia, which you can see the fat in the middle of the screen. So then I'm placing this reservoir under direct vision underneath the transversalis fascia because this patient had a, quote, hostile pelvis because of his bilateral inguinal hernia repairs with mesh. Again, there's isolation of the demonstration of the nerve. The corporotomy incision is, of course, made as you would routinely make. This is lateral to the cavernosal nerve and incising down into the smooth muscle. Use a Brooks dilator from the infrapubic approach because it keeps the dilator off of the abdomen. And this is, again, just routine measurements with the furlough insertion tool. And we can see the length that's here. From the infrapubic approach, I never use more than 3 centimeters of rear tip extender. And this is a patient now that after his implant is in place, he still has a very significant curvature. And this would be not lending itself to modeling. So modeling didn't work in this particular patient, and it generally doesn't for curvatures greater than 30 degrees in my experience. So the patient now has his implant. You do the subcoronal incision. You incise down through Buck's fascia. And then after it's open, you'll deglove the penis. And to do this process, I have the implant inflated because what it does is it really makes it very easy to get the neurovascular bundle off of the dorsal aspect of the penis. So now we're just incising Buck's fascia, degloving the penis as we routinely would, incising it to the base. And then what will be accomplished next is to go and isolate the neurovascular bundle. So I'll isolate and mark the most concave portion of the curvature. And after that's done, again, I'll start lateral by the corpus spongiosum, and I'll come all the way across. And by doing this technique, starting very laterally, as you can see, coming into the neurovascular bundle, I've had less hypoesthesia. In the early days, I used to just go lateral to the nerve and start. So by going down low by the corpus spongiosum and then coming up to the neurovascular bundle, I've had less hypoesthesia because I think there's some tissue that butts up to it, part of the area. And then this is just the isolation of the neurovascular bundle. So after the neurovascular bundle is isolated, as you can see here, again, I'll mark the most concave portion of this curvature. And then what I will do is I will put the cut of the cautery on 20. So don't use coag, use the cut, so it won't damage the silicone fibers. And so it's on 20, so it's on low energy. And then what I will do is I will cut in until I can see the cylinder, and you can actually see the penis release. It's amazing once you get the most constrictive part of the Peyronies process released. So I'll release it. I'll go on the contralateral side and I'll release it. And again, the neurovascular bundle is being elevated, so it's not damaged. And then once I've released this entirely, then you can just actually feel how this thing will snap. And then you can see the prosthesis has been shown here. And because of that, now that penis is straight. So now that defect, because it's greater than 1 centimeter, needs to be grafted. People say, well, what if you make a little incision into the tunica and it's not greater than 1 centimeter? Well, if the prosthesis is left inflated, it will granulate in eventually. But if it's greater than a centimeter, you need to graft it. So basically, I've measured the defect. Again, in this particular situation, I want to make this graft only 10% greater than the defect, because I do want some contraction of the graft on top of the cylinder. So that way there's no fluid that collects between the cylinder and the graft. And then I'll place the graft in, and then I'll just use 4 PDS sutures. So everything I've done up to this point is with the implant inflated. I wanted the isolation of the neurovascular bundle to occur with it inflated. And of course, I wanted to measure the defect with it inflated. But now at this particular point, the device is deflated, because sure enough, I'd stick that cylinder about 50 times. So again, it's just deflated, it's out of the way, and it actually makes it very easy now to just take the tunicle edge up to the graft itself. I take about a millimeter bite, as you can see, because I want it to be occlusive. I don't want any drainage of blood from this particular process. And then after it's been sewn to a certain point, I pass the needles underneath the neurovascular bundle, and then I continue sewing until it's all completely sewn in. When patients have this type of procedure, I leave the device about 50% inflated for 4 weeks, because I don't want the graft to be bent, or I don't want it to be, worn, the penis worn a certain direction to let the graft fold on itself. So I'll leave this particular device inflated for 50% for about 4 weeks. And then I bring them in and they start cycling it at that point. I let these patients start intercourse at 8 weeks. And then after that, these patients, I have them cycle it for the first 2-3 months every day for about 10 minutes, just to get that to be expanded. And here you can see the graft is sewn in, the neurovascular bundle's laid back down, and there is the post-operative erection that you can see afterwards. And you can see how the graft is taut, but it's still a little more supple than being 100% cut to fit. And that's the post-operative result. Close them up. This is how I place my pump. And then I use the most lateral aspect of the dependent portion of the hemiscrotum, and it's lateral to the cord and the testicle, and it's positioned down in this location. And then you just close the penis, and then the dressing is applied. That would be good, Emmett. That's good.
Dr. Amit, who has given the clarion call of straightening the curve, he is a par excellent human being first.
Thank you so much. I just wanted to let you know before that last talk, please go ahead and post some questions in the chat box, because after this, and I'm very, very happy that there was no drop-offs despite this video. In fact, I was debating whether to play the video or not, because this is going to be a general session. But a lot of people actually wanted me to continue the video because they would like to see. It's just like me wanting to watch a heart transplant surgery. I'd love to watch it, even though I'm not a cardiothoracic surgeon. So I hope you guys enjoyed Dr. Noel's thing. And I'll let Rajesh introduce me as the last speaker. And I encourage you to please post some questions and answers in the chat box. Thank you.
Dr. Amit, who has given the clarion call of straightening the curve, he is a par excellent human being first, and he is a urologist at Buff Regional Medical Center. He has been practicing there as urology, and he has basically he's an alumni of PGI Chandigarh, and we are all glad to have him on board. Dr. Amit, we are all raring to hear your guidelines.
So there's no disclosure related to this topic. Basically, hang on one second. Let me just, okay. So this guideline was published 5 years ago, and that included a systemic review of literature using PubMed, Embase, and Cochrane databases. And as you know, as per any guidelines, there are the different levels or strength rating of the guidelines, which is A is high quality with good evidence, B is moderate quality, C is low quality. Then there's evidence-based treatments, which is strong, moderate, or conditional. And sometimes there's a clinical principles and expert opinion when there is not enough evidence available. So going over the diagnosis, the guidelines are the clinicians should engage in a diagnostic process to document the signs and symptoms that characterize Peyronies disease. And Dr. Mills has actually covered that. We have to do a careful history to assess the penile deformity. We'll have to really find out whether it interferes with the intercourse. There are people who have curvature, but it doesn't interfere with intercourse. And some people actually say that they enjoy it or their partners enjoy it, and we don't need to interfere with that. Whether there's any penile pain and or distress, that's important because of treatment purposes. Landon Frost has actually alluded to that a little, and I'll go over that in the treatment guidelines. Of course, you have to do a physical examination of genitalia to assess any palpable abnormalities of the penis, like plaque size, induration, hourglass deformity. Well, at this point, you cannot assess the hourglass deformity. That's after performing an in-office intracavernosal injection test with or without Doppler ultrasound prior to invasive intervention. Now, not many people in practice use Doppler ultrasound for this. I just do an in-office intracavernosal injection, and I have got a disposable curvature measurement where I can measure the curvature. Previously, there was one of the universities, I don't remember, Pennsylvania, had a little beautiful app which we could actually take a picture, and that not only shows the curvature, it gives a dot picture of that, and that dot picture can be easily put on the patient's EMR, electronic medical record. So that's no longer there. However, this is to assess the degree of curvature so that you can counsel the patients better. Clinician also should treat a patient with Peyronies disease only when he or she has experience and diagnostic tools to appropriately evaluate, counsel, and treat the condition. So the treatment options are, we have to discuss with the patient the available treatment options and the known benefits, risk, burden associated with each treatment. This has been adequately covered by Dr. Levine and Dr. No, where we're going to do a traction, we're going to do plication and or grafting with or without penile prosthesis. You may offer oral non-steroidal anti-inflammatory medication to the patient suffering from active Peyronies disease who needs pain management. So during the first part of it, when there's pain, where surgery is contraindicated, you can offer them some NSAIDs. Clinicians should not offer oral therapy with vitamin E, tamoxifen, procarbazine, omega-3 fatty acids, or a combination of vitamin E and L-carnitine. This is a moderate recommendation, and this has been very clearly covered by my previous speakers, including Dr. Mills and Dr. Trost. Also, we should not offer electromotive therapy with verapamil. All right. So again, treatment options: clinicians may administer intralesional collagenase in combination with modeling. This is Xiaflex. And this should be used for patients who have penile curvature more than 30 degrees and less than 90 degrees with an intact erectile function. That intact erectile function could be with PDE5 inhibitors. And then the patients who counsel patients with Peyronies disease prior to bringing treatment with intralesional collagenase, because there are side effects of penile ecchymosis, swelling, pain, and there have been incidents of corporal rupture when they do the modeling. Clinicians may administer intralesional interferon alpha 2B. That's a moderate recommendation. Again, you should go over the side effects or potential adverse effects, including sinusitis, flu-like symptoms, and minor penile swelling. Also, Larry Levine championed this in the early 90s, like he said, intralesional verapamil for the treatment of patients with Peyronies disease. And this is a conditional recommendation with evidence grade C, only because, as Dr. Cross pointed out, there have been no studies which actually shows a definite improvement. But again, these guidelines are from 2015, We have learned a lot since then, and I'm very, very keen to know what will happen in the new guidelines which are coming out, which Dr. Trost is a part of. Clinicians should counsel patients with Peyronies disease prior to beginning treatment with intralesional verapamil. Again, the adverse effect like penile bruising, dizziness, nausea, and pain at the injection site. Clinicians should not use extracorporeal shockwave therapy for reduction of penile curvature or plaque size. And we don't offer that to anyone. However, if the patient is in early stages with penile pain, you may offer that. Again, it's a conditional recommendation, and the evidence strength is grade B. Clinicians should not use radiotherapy to treat Peyronies disease. Again, this is quite a moderate recommendation. Clinicians should assess patients as candidates for surgical reconstructions based on the presence of stable disease. That's been alluded to by my previous speakers, that during the pain stage, during the initial stage with the plaque size and curvature will vary. You should not offer surgery. You should wait till the disease is stable and then discuss surgical options. Clinicians may offer tunical plication surgery where the rigidity is adequate for coitus, with or without pharmacotherapy or vacuum erection device. This is to improve penile curvature. They may offer plaque incision and or excision and or grafting to patients whose rigidity is adequate for a coitus, again, with or without pharmacotherapy or vacuum erection device, to improve penile curvature. So bottom line is that if the patient has adequate erections with or without PDE5s or vacuum device, we can either offer them plication or grafting, depending on the amount of curvature and penis size and the patient's, what the patient wants. Clinicians may offer penile prosthesis surgery to patients with Peyronies disease with erectile dysfunction and or penile deformity sufficient to prevent intercoitus despite pharmacotherapy or vacuum erection device. It's a moderate recommendation. Clinician may perform adjunctive intraoperative procedure like modeling, plication, incision grafting when penile deformity persists after insertion penile prosthesis. Again, Dr. Knoll has alluded to that and actually covered this quite eloquently. Basically, modeling only works, I agree with him, if it is less than 30 degrees. We used to do that in the past. However, when you do modeling with the penile implant in place, make sure you put rubber shots going to the pump. Otherwise, I don't know with the recent release valve, but previously we used to, when you model it, we make sure that it doesn't go back to the pump and damage the pump mechanism. But it only works in less than 30 degrees. Plication, again, if the penile length is adequate, the deformity is quite severe, and there's a deformity of more than a centimeter, like Dr. Knoll said, we need to put a patch. If it is less than a centimeter, you can leave it inflated and wait for granulation tissue to build over it. They should use inflatable penile prosthesis for the treatment of Peyronies disease. And in this thing, if for AMS, they advise to use the CX and not the LGX, but CX has got a little bit more firm rigidity, and we don't want the LGX is less preferable. So I'm going to, these are the AUA guidelines. I'm going to touch on European Association of Urology guidelines and just point out the differences. Essentially, they are the same. However, a few things which they have in their guidelines, which is not covered in the AUA guidelines, they actually, in the medical history, duration of disease, penile pain is very, very significant in that. Also, they also can assess extent of curvature by self-photograph. So, so in Europe, we can actually ask the patient to take a photograph of an erect penis when they come, or after vacuum erection device, they can take a picture. That way, they don't have to have an intracavernous injection in the office. I don't use it that often. Occasionally, I have used it. They've also alluded to ruling out the other diseases which are supposed to be associated with Peyronies disease, like Dupuytren's contracture, Lederho's disease. So apart from that, the others are quite the same. We use Doppler ultrasound only to ascertain vascular parameters for erectile dysfunction. Now, for the management, first you use conservative management when surgery is not acceptable to the patient, or if the patients are not fit for surgery. If they've got other comorbid factors and they're not fit for surgery, we can try vacuum device or the traction devices. We should not use extracorporeal shockwave treatment, and we know that. We've talked about vacuum devices and penile traction. Do not use intralesional treatment with steroids. That's contraindicated. Again, don't use oral treatment. That's also been covered in the previous guidelines. You should perform Peyronies disease with a stable for at least 3 months. Here, they vary. I think most of us here in the US, we wait for 6 months to a year. I would like the panelists to address that. I usually wait 6 months to a year, and at least 3 months after the pain has completely gone. Again, if you use tunical shortening procedures, especially plication technique, you should use that as the first option for congenital penile curvature and for Peyronies disease with adequate penile length and curvature less than 60 degrees, in absence of special deformities like hourglass and hinge. So again, the others are same. The types of grafts which they have covered is autologous, allografts, xenografts, and synthetic grafts. All these grafts have been used in the past, but I think most of us now use pericardium, or Dr. Knoll has championed SIS. Occasionally we have used dermis, and there is a new, the dermis preparations may be something to fall back on, because we had a shortage of pericardium, bovine pericardium, turoplast recently, and I had to use dermis on one of those patients. So the treatment, again, of Peyronies disease, you should discuss the natural history of disease, reassure the patient that Peyronies is a benign disease, discuss the current treatment modalities, and use a shared decision-making as to what to do. And with active disease, pain, deformity, deterioration, no calcification, on ultrasound, we use conservative management, stable disease, no pain, no deformity, calcification, curvature less than 30 degrees, no severe deformities, no ED, no further treatment. Above 30 degrees, severe deformity, ED, we use surgical treatments. Thanks a lot. Thank you very much.
Yeah, thank you. Before we, I really appreciate, this is a great workshop. Congratulations to all of you. Just a reminder, we lost about 5 minutes because of the technical glitch, which was corrected, obviously. And so I'm going to extend it 5 more minutes. So we will have, now it is almost 12:50. So we got 15 minutes of the discussion and the question and answers. Thank you.
Great. Thank you, Dr. Murthy. I hope everybody enjoyed it, and I see no attrition in the count. I mean, everyone who logged on has remained on, which is very, very great. So let me, before we start the question and answers, and I introduce my moderator who is going to pitch the question and answers, let me tell you about how we came around this, let me just see, slideshow. So basically, I came across this quote from Martin Luther King, which is appropriate for today's talk. The arc of moral universe is long, but it always bends towards justice. So when we started this talk, we call it Meocon Manthan. Let's flatten the curve. I came up with this, then this actually caught on. When it caught on, I said, well, you know what? Let me, in my WhatsApp groups, ask them for any other suggestions of topics. So I just wanted to, just as a little lighter note, these are the topic naming contest finalists. God threw a curveball, bend it like Beckham, Peyronies, crooked macaroni, the tale of crooked Peter, Banana Rama, Benders Fixers, Mend the Bend, and there was one more called Boomerang Man. But the winner is a Indian Hindi topic, which my foreign, my American colleagues may not understand. But I thought this was the best. Mud Mud Ke Na Dekh Mud Mud Ke. There's a song from Sri 420 called Mud Mud Ke Na Dekh Mud Mud Ke, and that is for me the best one of that. So I want to introduce today's person who are actually going to ask the topic questions. Pramod Krishnappa, he's the consultant of Andrology Division of Department of Urology at NU Hospitals, Bangalore, and he has been done fellowship in Spain, Belgrade, and Chicago. So without further ado, please, I'll stop my screen sharing and have Pramod ask all the questions.
Dr. Amit. Yeah, so we have Trost and Dr. Amit. I will be asking most of the questions to the Trost, one of the senior faculty and an expert in the Peyronies disease. And I assume that many of the audience here are non-urologists. So at the end of all these discussions, what we need to understand is that anybody who comes with a penile pain is not just an urinary tract infection. It could be a patient who has an acute phase of Peyronies disease. Yeah. Okay. Dr. Trost, are you there?
I am, yeah. Thank you.
Yeah. Hi. So just a few questions about the acute phase. What is your preferred drug? Like I use a tadalafil. There's some evidence to say that it causes some penile scar modeling. So I use a low dose. That expensive tadalafil. So I use it. So what is your preferred choice in the acute phase?
Yeah, and I'm sorry, I think your audio may be cutting out a little bit. So, but I think you were saying you use tadalafil as a preferred because it's less expensive and it's available. So in the acute phase, usually I say there's things you should do, things you could do, and things you shouldn't do. Should do, I say, is traction. There's that good study by Martinez and Salamanca's group out of Spain, which showed that if you do traction immediately in the early phase of disease, you get a less severe curvature than you would otherwise. Unfortunately, there's no real medicine that has been shown in the acute phase with any reliable or consistent data to do much. So I think you can do something. PDE5s are just as good as anything. I mean, they are going to cause some internal traction, but meds like pentoxifylline, L-citrulline, all these ones that have been used for a long time, they were really kind of based on bogus data. And a lot of the, the original randomized controlled trial on pentox was pulled from the literature for falsification. So really meds, I don't strongly recommend. If anyone wants me to prescribe it, I'll do it. And of course, the thing you don't want to do in the acute phase is surgery. And so that's usually the thing you don't do. The things you could do is injection type therapies. But really in the early phase, the key thing is start treatment as soon as possible with traction to prevent it from becoming as bad as it might otherwise.
Okay, thanks for that. And about the penile traction devices, can this be used or prescribed by the general practitioners in the US? Is it possible? And is this covered by the insurance company? I know you're one of the experts in the penile traction devices because you came up with the new latest Restorex. I was involved in Master Pro study. I was the second author with Moncada, where the main issue was that we had to instruct patients to wear it for a very longer time, 4 to 6 hours. And the Restorex is just, you can use it for just 1 or 2 hours. So could you please elaborate on that?
Yeah, well, so as far as your earlier question, can anyone prescribe it? I can't speak to India specifically, but in the United States, definitely anyone can prescribe it. It doesn't even require a patients just can get it directly without any sort of prescription or anything like that. Insurance often does cover it, but it does take, applications and things for it. And usually they only cover about a quarter of it. They can be covered by health savings accounts or things like that. And yeah, as far as the traction, I had no intention of ever inventing a device for sure. But what I found was at Mayo, we prescribe these, and the recommended time is 5 to 9 hours, depending on the specific device for it. And even the people who did wear it for 9 hours, surprisingly, there were some who did. When we tracked their outcomes, they didn't do anything. So I went to the engineers at Mayo and drew some designs and said, this is what you need to design. And so the device we built was a lot more, you got a lot more traction out of it. It did about 7 pounds of force compared to 1 pound. And I think because of that, that's why you only have to do it 30 minutes a day as opposed to 9 hours a day for it. So.
Okay, thank you. And about the collagenase injections, they are very expensive and practically not possible in India. So and are these covered under insurance in the United States? And how is the receptibility of these with the patient?
Yeah, good question. So the far majority are covered because it's FDA. It's the only FDA-approved medicine for Peyronies. By law, Medicare covers it. And whenever Medicare covers something, usually most insurances follow suit. I've only found about 3 insurances over the past 6 years who don't cover it. So it's by far covered by most insurance providers. As far as costs, the company has a reimbursement for patients up to $1,200. So unless they have just a massive deductible, most patients will end up with nothing out of pocket. The advantage of it is it's really the only viable therapy that can prevent surgery. And by far, the majority of patients don't want surgery if they can avoid it. So it's a viable, first time we've had really a viable non-surgical option.
Okay. Thank you, Dr. Trost, for all those wonderful answers. And Dr. Amit, what is your preferred graft?
So just want to address a little bit about the previous question also before I go to this question. I was just about to say that Xiaflex is an expensive treatment option. And me being in private practice, I know that we have to do a lot of my staff has to spend a lot of money with the insurance company trying to okay it, because each of the injection, one session that involves 2 injections costs $8,000. If I'm correct me if I'm wrong, Landon. That's a lot of money, and a few insurance companies pays for it. And I have not personally, and Landon may may not agree with that, but I have not found that much of a benefit to that. So a person, if I understand in India setting, if a person is told that we can use that, but the chances of success is less than 50%, and the cost is that much, it's kind of a little bit tough sell. And that's the reason I have used that for people who really are not a good candidate if their insurance covers it, and something we need to do if they don't want surgery. Coming back to your answer about the type of graft material, I use bovine pericardium called tutoplast, and I've used that for a long time. People have used actually Tom Lu has grafted, taken a venous graft and used that. That's a very big donors thing. So I've used tutoplast, which is bovine pericardium, quite nicely. Now we have got this new dermis called Derma Pure, and that I'm going to try using that especially because tutoplast is in short supply. Sometimes we don't get it, and I have to dip back on dermis, which I used to use before I started tutoplast. So I went from dermis to tutoplast, and now I'm going to go back to the acellular dermis, which is coming new into the market. Landon, what are your thoughts?
Yeah, for grafts, the big problem is I agree with tutoplast. It's so very expensive. And so usually what we try to do is use a testicular graft. So if you just deliver the testicle, you take the tunica, you essentially have an unlimited size graft. It's durable. It's the morbidity is not that much more. You're already down there, and you just do a local block with it. So that tends to be my go-to. Taco Seal, I liked it at first. It was it's a trendy graft. I'll be curious to see 5 years from now, what the patterns are. But the problem with Taco Seal, when you use it, when you place it on the graft bed, you can't test the erection afterwards. And when you're doing incision and grafting, I've never been able to fully correct a curve at the first go around with incision and grafting. And so it makes me really nervous that I'd have to guess what my residual curvature is going to be. So in general, I haven't, the only role I put with Tocosil is if you have like an hourglass deformity and you need to fill it out, for example, but I don't use it as a primary graft material typically.
Guys, for people who don't know what Tocosil is, it's a collagen fleece. The advantage of that you don't have to put a stitch on it. You put it on the prosthesis. So people who are scared about putting stitches when the inflatable penile prosthesis is there, because they don't want to puncture the prosthesis, you can put this fleece. There are mixed feelings out of it. I have not used it. Dean Knoll also doesn't use it, and he told you very clearly that that he doesn't have any problems puncturing the prosthesis if you do it carefully.
Okay, thanks, Dr. Amit and Dr. Trust. And about the penile prosthesis in India, it's mainly the malleable we use, and I know in US it's mainly the inflatable ones. So in what situations do you use a malleable implant in your clinical scenario, Dr. Trust?
Well, so typically we'd use it kind of in limited settings.
Any role
we would use malleable? It if, sorry. Yeah, so in a clinical setting, we would use it if the device were infected, like a three-piece were infected, we were swapping it out and we wanted to put a temporary kind of placeholder in. Some men just can't use the pump. The pump is pretty difficult with the inflatable prosthesis. And so if they don't have the dexterity or hand function to be able to use it, we do it. In particular, if someone who just needs to keep kind of a catheter. But with malleables, I mean, just such a high rate of them erode with time, almost no matter what you do, that, you know, any chance you get an inflatable tends to have advantages over it. But I you know, do hear what you're saying, and it is a challenge if you're, you know, limited on what options you have to place. I really think it's an opportunity for someone to innovate a distal sock, almost like a windsock type repair that you do for proximal perforations. I think that should be done distally to prevent these from eroding so easily.
Okay, thank you, Dr. Trust. And Dr. Amit, regarding the shockwaves disease, because nowadays we see these shockwaves are very commonly used in India. Are these very commonly used nowadays? The shock.
No, the shock waves, your internet kept on coming in and out, but I understand this is going to be the last question because we, Dr. Murthy is very particular on time. We'll just keep to the time. So just to answer your question, shockwave lithotripsy has not shown the promise as it did before. I don't use it routinely in my practice. I'll have Landon have the last say on that.
No, I totally agree. I mean, it's kind of the latest snake oil in sexual medicine, in my opinion. It has never met the threshold criteria of being the minimally clinically significant difference for erectile function. It's kind of the 2020 way of you know, separating out the scam from the true, you know, sexual medicine practices, in my opinion. So
that's true. That's true. Okay. Dr. Murthy, over to you, sir.
Thank you so much. I really appreciate it. It's a good timing. It has been a phenomenal.
Okay, thank you, Dr. Trust. Dr. Amit, you can take it forward. Yeah.
It has been a very productive workshop. A lot of interactions with you know, our Indian colleagues, talking out of experience, and I really enjoyed the discussions here. So for those who are eligible for the CME credits, please don't forget to submit your pre and post surveys. At this point, I request our RP President, Dr. Sudhakar Janalagadda, to recognize our distinguished speakers. Dr. Janalagadda.
Thank you, Dr. Murthy, for outstanding webinar today, this afternoon. And this is quite new for a lot of members because it's some subspecialty topic. And Dr. Amit, thank you very much for doing this. And I'm sure, you know, everyone had enjoyed this talk, actually, including myself. It is my honor to recognize today's speakers. Vijay, can you put the clock in? It's my honor to recognize Dr. Landon Trust, MD, on behalf of American Association of Physicians of Indian Origin, with deep appreciation for your extraordinary leadership and the service to the profession and community. Sudhakar, General Secretary President, Dr. Emul Murthy, MD, API webinar CME Chair, October 31st, 2020. Dr. Ross, these plaques will be mailed to you soon, and we are presenting virtually today. Thank you very much for joining today. Thank you.
No, thank you.
Next one. The next one is recognizing Dr. Amit Chakravarti, MD, with a deep appreciation for your extraordinary leadership and service to the profession and community. Sudhakar, General Secretary President, and Vemuri S. Murthy, CME Webinar Chair. Thank you, Amit, for your outstanding leadership as a Secretary of the organization and as well as a good speaker. Thank you.
Thank you so much. And I also want to take this opportunity for the three young moderators from India. Very quickly, if you can project their certificates of appreciation quickly, can you project all those three? Thank you so much. That's my personal request to Dr. Murthy and Dr. Janala Gada. We appreciate you taking your time off. It's late in India. This is Dr. Pramod K for doing this. And then we have Dr. Rajesh Gulia and Dr. Aditya P. Sharma and Dr. Gulia. Thank you so much. And I appreciate all of you guys for attending. And I hope it was a knowledgeable session. It's a subspecialty, but all of us have patients who come to you with Peyronies disease. And it's kind of a general knowledge to know what to tell them, what is there out there, and what works, what doesn't work. So thank you very much for the opportunity, Dr. Murthy and Dr. Janala Gada, for addressing a urology topic in this sessions. Thank you.
Yeah.
Thank you. Stay safe.
All these senses, the CME session.
Thank you.
Thank you. Stay safe.
Thank you.